This is my honor to introduce our speaker, Dr. Anthony Drago, as we also call him Tony. Dr. Drago is a chair and professor of psychology at Strathmore University. He's also a psychologist in private practice and consultant to numerous behavioral health agencies in the Pocono Mountain region of Pennsylvania. Dr. Drago's areas of expertise include DSM-5, suicide trauma. He has lectured on numerous occasions in the US, China, and Costa Rica. His current research interests include self-efficacy, locus of control, suicide subtypes, and caregiving response to autism. Please join me to welcome my dear friend and colleague, Dr. Tony Drago.
Thank you. Okay, well, welcome, and hopefully I'll be able to impart a lot of information to you about suicide, because there's a lot of information that needs to be said. I always like to start a presentation with a story, so if you bear with me. This is a story about a bridge. And this bridge is 75 years old. And when it was built, it was a marvel, and it still is. This bridge is 25 stories high. If you were to jump off this bridge, it would take you 4 seconds to reach the water, and you would travel at about 75 miles an hour. There's been greater than 1,300 documented suicides off this bridge. Documented means it was witnessed by at least 2 people. The belief is that there's been over 2,000 suicides from this bridge since it opened in 1937. The staff on this bridge stop about 2 to 3 people from jumping every week. What bridge are we talking about? What bridge? Golden Gate, the Golden Gate Bridge. The Golden Gate Bridge, where I understand just recently and finally they put nets underneath. For many years, people have asked and begged to put nets underneath the bridge, but the owners of the bridge didn't want to because it would disturb the ambiance of the bridge. But now they finally put nets under it. This individual here, his name is Kevin Hines. He was on campus about 3 years ago. He is one of the few people that jumped off the Golden Gate Bridge to commit suicide and survived. And he has a very interesting story that he told us a few years ago, and have a little video clip that I'm going to show you of Kevin Hines talking. But before I do that, there's been research on 515 of those individuals who were restrained from jumping off the bridge to kill themselves. At the end of the first year, 95% of those restrained had not gone on to do anything to themselves. 16 people jumped but did not die, Kevin Hines being one of those. No one who jumped and survived ever tried again. Here's the frightening thing. Of these 16 people that were interviewed, all of them, including Kevin Hines, said after they jumped, their first thought was, shouldn't have done this. I want to live. So there's no reason to believe then that those who jumped and died didn't have the same thought. So now I want to just show you a little clip of Kevin Hines talking about his experience. So, Emily?
Faith of walk far too many lives, traveling the path
Since 1937, over 2,000 people have died at the Golden Gate Bridge. I feel lucky to be alive every single day. Of the thousands that have died off the Golden Gate Bridge, I am of 1% who have survived. So I was born on drugs and premature. And then I bounced around from home to home. Nobody wanted to keep me because I was sick. And I got lucky. I landed in the home of Patrick and Deborah Hines. I had a great childhood. I thought, growing up, that everything's going to be great. And then at 17, it all came crashing down. You can imagine feeling that everyone around you is out to get you, trying to hurt you, and trying to kill you. And you believe that to be the truth. From the extreme paranoia, I exhibited symptoms of mania. From the mania came the hallucinations, both auditory and visual. And so with that and the bipolar disorder, I just was spiraling out of control. I vividly remember writing my suicide note. People don't get it. Like, I thought I was a burden to everyone who loved me. Because that's what my brain told me, because that's how powerful your brain is. I got off the bus. I walked slowly down the walkway of the Golden Gate Bridge. People rode by me, drove by me, walked by me, and a woman approached me. And she said, "Will you take my picture?" She said thanks, and she walked away. In that moment, I just said, nobody cares. The reality was that everybody cared. I just couldn't see it. I ran forward, and using my two hands, I catapulted myself into free fall. What I'm about to say is the exact same thing that 19 Golden Gate Bridge jump survivors have also said. The millisecond my hands left the rail, it was an instant regret. And I remember thinking, no one's going to know that I didn't want to die. In 4 seconds, I fell 75 miles an hour, 25 stories, and I hit the water. I was in the most physical pain I had ever experienced. I have ever experienced. The Coast Guard was amazing. He was just so freaked out that I was alive that he just dove in and brought me on board. And I said, "Do you know how many people we pull out of this water that are already dead?" And I said, "No, and I don't want to know." The guy put his hand on my forehead and said, "Kid, you're a miracle." My father took one step into the hospital room, and I looked up at him and I said, "Dad, I'm sorry." And he said, "No, Kevin, I'm sorry." And if you think about it, both of our immediate reactions were guilt. Guilt that didn't belong to either of us. And even though I didn't die, I caused people a great deal of grief and pain. Just the day of my attempt still sits within them today. I asked my father if he still feared my death by suicide. He said every time the phone goes off, his first inclination is Kevin alive. I had that impact on my dad. So after the jump, the road to recovery was pretty long. I had 7 psych ward stays in the next 11 years. I still have all the symptoms I ever had. Mania, depression, psychosis, hallucinations, all that's still there. I just know how to cope with it and I know how to beat it. I built a support network over these years of treatment so that I wouldn't be fighting this alone. So it's okay not to be okay. It's not okay not to ask for someone to back you up. To the families who live with the losses of loved ones, they didn't do that to hurt you or destroy your life. They took their lives because they were struggling and in a great deal of emotional and mental pain. Suicide, mental illness, and addiction are the only diseases that we blame the person for perpetually. But people die from suicide just like they die from any other organ diseased. Today, no matter the pain I'm in, no matter the struggles I experience, I do believe that life is the greatest gift we've ever been given. And if you're suffering mentally, don't wait like I did, sitting in denial for so long. Because recovery happens. I'm living proof.
Oops. Okay, a very powerful message, right? Very powerful message. Okay, so the definition of suicide seems relatively simple, purposeful taking of one's life, but suicide behaviors fall on a continuum. So I just want to go through some of the terms that we generally use. So suicide, that's what that is, an intentional, self-inflicted act that results in death. It's also synonymous with completed suicide. The word successful suicide we don't want to use. Completed suicide, right? Then we have suicide attempt with injuries. Okay. The intention was to die. You can also, of course, have a suicide attempt without injuries. And then we can have just a suicide threat. This is an action where a reasonable person would believe that the individual is making a threat to kill themselves. And then we have suicidal ideation. These are just thoughts, right? Not all thoughts need to get into behaviors, but that's known as suicidal ideation. And now we have something very interesting. It's called non-suicidal self-injury. It's not a formal diagnosis in the new DSM, Diagnostic and Statistical Manual, but it's in the category needs more research. And these are the individuals who will inflict harm to themselves, cutting themselves, burning themselves, that sort of thing. But they're really not intending to kill themselves. Sometimes it's to punish themselves. Sometimes it's to feel pain. Sometimes they feel detached from themselves, so they hurt themselves in order to feel. A lot of adolescents end up doing this, and it's a tremendous problem. I could spend a whole other hour talking about that. And then we have something known as, instrumental suicide-related behavior. It's a long name. But what this is there's evidence that the person really didn't want to die, but they used the appearance to commit suicide for some other reason. And typically, and sadly, it's leverage in a relationship. You sometimes will hear them as though they're trying to get attention. We don't say that. We say they're trying to communicate something, or they're trying to control something. And it can be very dangerous. Some of these individuals do end up dying, but really by accident. Time permitting, I'll spend more time at the end of this talk talking about this. Okay, now we can't separate out suicide from mood disorders because mood disorders and suicide are linked. And certainly depression is one of the mood disorders that is connected to suicide. And I want to talk a little bit about depression, and I want to talk a little bit about the symptoms of depression. But I always like to start out talking about depression by talking about many people throughout history that have had depression. Because I want you to clearly get the idea that depression has nothing to do with will. It has nothing to do with willpower. Nothing at all. Now, why do I say that? Well, I say that because Winston Churchill. Who had more willpower than Winston Churchill? He was the Prime Minister of England from 40 to 45 and then again from 51 to 55. And when he would get depressed, he had a great term for it. He said, "The black dog has me." That was his sign that he was getting depressed. A lot of other people throughout history have suffered from depression. Princess Diana, she died in 1997. Buzz Aldrin. Some of the older folks in here remember the space age, and when astronauts were selected, they were the top of the top. They were the best mentally, intellectually, and physically. They were put through countless tests And yet, somebody like Buzz Aldrin, I think he was the second man on the moon, he suffered from depression. Isaac Newton suffered from depression. Mike Wallace suffered from depression. This is just a partial list. There's just countless people. Anybody know who Thomas Eagleton is? He was senator. He was a senator from Missouri. And he was the running mate of 1972. McGovern, running mate of George McGovern, who was on the ticket for about a month. And then it was discovered that he was treated for depression in the past and received ECT and was immediately thrown off the ticket. Oh, politics, yes. Okay. Now we get some contemporary, and some students get surprised at this. J.K. Rowling suffers from depression. Marie Osmond suffered from postpartum depression. Anyone know who this is? I just had to throw this one in here. Anyone know who this is? She's an actress, and she's best known for her role as a psychiatrist on The Sopranos. A lot of students really get surprised at this because you all know Bradshaw as what? The commentator, humorous commentator, right? I'm a Steelers fan, so I know him in a different way. But when he talks about his depression, it's heart-wrenching, right? He's had serious bouts of depression throughout his life. Chevy Chase, Marlon Brando, best known for The Godfather, best movie of all time, best line in a movie of all time. Anybody know what that is? Leave the gun, take the cannolis. Okay. Heath Ledger. Okay, Heath Ledger. 2008. Just a few more. Drew Carey. Usually when I put this next one on, people don't realize that he served as a Marine. Brooke Shields, also postpartum depression. Jim Carrey, oops, sorry about that. Jim Carrey. A lot of comedians. Sheryl Crow. Janet Jackson. Billy Joel. Billy Joel. He was hospitalized for a suicide attempt. And I think one of his daughters also. I was at a concert at Billy Joel last year at the Garden, and he's still remarkable. And the thing that really surprised me the most is that students knew every song and were singing every song that he had, which was really shocking to me, to the point where I couldn't hear him, but okay. And Kurt Cobain. Remember Kurt Cobain? Singer-songwriter from Nirvana. I put here depression, suicide, question mark, because I did see that Netflix show, Cleaning with Bleach or something like that, which raised some questions, I guess, whether it really was a suicide or whether Courtney Love had something to do with it, I don't know. But here's the frightening thing, and we're going to talk about this a little bit later. Look at this next little slide here. 68 documented suicides after his reports of suicide. This becomes a problem, right? We're going to talk about this shortly. This contagion, this suicide contagion, this modeling of suicide becomes a real problem. Michelangelo. And of course, Robin Williams. Some recent information is coming out that Robin Williams may have been suffering from Lewy body dementia and maybe killed himself for that reason as opposed to depression. Okay. Now, let's just talk about mood disorders, okay? So mood disorders, this affects the individual's emotional state. And as most of you know, it can be the form of extreme depression, extreme elation, or both. Depression, we say it's dysphoria, and mania, we say it's euphoria. And so these are the general symptoms of depression. There's these emotional symptoms, this miserable feeling, this empty feeling, this numb feeling. In my private practice, I often hear people that are depressed, they tell me that they're feeling numb. It isn't like they're sad and weeping openly. They feel like nothing. Numb is a good way of describing it. They experience little pleasure. Things that used to give them pleasure no longer give them pleasure. We call that anhedonia. There's motivational symptoms. Lack of drive, lack of initiative, they lack spontaneity. And about 6 to 15% will kill themselves. You're going to see why there's a range there, because trying to get accurate suicide numbers is very difficult. More symptoms of depression. There's behavioral symptoms. They're less active, they're less productive, and there's a lot of thinking or cognitive symptoms. Very negative views of themselves, very pessimistic, and many people that are experiencing depression also have a host of physical symptoms. So diagnosing depression, technically you would need 5 or more of those symptoms for 2 or more weeks. And in extreme cases, the person can be psychotic. Kevin Hines talked about extreme paranoia. So he was psychotic, probably experiencing bipolar disorder, which I'm going to talk about shortly. Okay. So we have major depression, which is the one that there's suicidal threats and often suicidal behavior. Certainly there's suicidal thoughts that go along with major depression. That's one of the criteria. But then there's something known as persistent depressive disorder. And this is this longer lasting 2-year, you're sort of functioning, but not really. You're not really functioning up to par. And so this is less disabling. These are the walking wounded. Now, I want to be very clear that you understand that depression is not the blues, right? We can all get the blues, right? We can all have a period of time when things in our life aren't really going well. That we call the blues. In fact, there's a lot of music made about that. That's not depression. And this slide comes from the National Depression Screening Day from a couple of years ago, but it's a really good slide because you see clinical depression, that's another word for major depression, is an illness. Sadness or the blues is a normal reaction. We've all experienced that. The symptoms, there's multiple symptoms with clinical depression, and with sadness or the blues, the primary symptom is sadness. Duration persists and brief. Clinical depression often results in at least suicidal thoughts and sometimes behavior, where sadness or the blues rarely produces that. Treatment, depending on the level of depression, the research is clear, at least the way I read it. Mild to moderate depression, psychotherapy alone is the treatment of choice. Moderate to severe, therapy and medication is the best treatment. And sadness or the blues, just a good listener, a good friend. Depression rates. 8% of adults per year, 19% during their lifetime. Similar in other countries, higher among the poor. Women twice as likely as men. But this becomes a little difficult. Because is it really that women are twice as likely as men to experience depression, or do women acknowledge it more than men? That's always the problem when you're looking at numbers. 85% of people will recover without treatment. Major depression tends to run its course. However, along with major depression is often suicidal ideation. And so we want to treat that. And 40% will experience another episode. There's many variables and there's many symptoms of depression. The symptom that is the closest correlation with suicidal thoughts and suicidal behaviors is hopelessness. So whenever we're evaluating somebody, we always try to evaluate the level of hopelessness, the severity of it, the duration of it, because people who have attempted suicide indicate that that's one of the primary reasons that they attempt suicide. Aaron Beck, a very famous psychologist from Penn, talked about these negative cognitions about the world, about the self, and about the future. And people that become suicidal have very negative views about themselves, about the future, and about the world. If you are okay about your future, you can think positively about your future. You may still think negatively about the world or yourself. That's going to help you not be suicidal. Conversely, you may think okay about the world, but not so good about your future or yourself. If all three of those are affected, there's a good likelihood that the person is experiencing hopelessness and will have suicidal ideation. Now, bipolar disorder, as many of you know, this replaced the term manic depression, and this implies two poles, mania and depression. The interesting thing, though, is not all people with bipolar disorder experience depression. I know this sounds odd because that's what it's called, but you don't have to experience depression to be diagnosed with bipolar 1 disorder. So what's a manic episode? Has anybody ever seen anyone in a manic episode? What's it like? Somebody, give me a couple of symptoms.
They're very negative about everything.
Negative about everything. Well, except themselves.
Yeah.
Sometimes. What else? What are some other mania symptoms?
They're agitated.
They're agitated. Yeah, they're crawling out of their skin agitated. Yeah. What else? Anybody else? Sid?
They're irrational.
They're irrational. Impulsive. Mm-hmm. It's like they're on an amphetamine, but they're not. That's the best way to really describe it. They're just wired. They talk fast, they walk fast, you can't follow what they're saying, they're grandiose, they can go for days without sleep. They just talk. Sometimes that's what professors do, we just talk. They have flight of ideas. You can't follow what they're saying. You're really trying to follow what they're saying, but you really can't. They're very distractible, they're agitated, and they engage in a lot of high, in behaviors that have high consequence for, high potential for painful consequence. Spending sprees, all of that type of stuff. So we have something known as bipolar 1, where you have a manic episode, and you don't have to have major depression. Most do, but you don't have to. And then we have something known as bipolar 2, which is basically mania light. It doesn't quite meet the bar of a manic episode. It's called hypomanic episode. And in this particular case, you have to have major depression. So these are just some of the statistics on bipolar disorder, certainly less than depression, but a very devastating illness. Okay. The onset is typically between ages 15 and 44. I could go on, but I won't, about the diagnosis of bipolar disorder in children, which I'll save that for another time because that's a problem. Okay, suicide myths. So now we're going to talk about suicide. So first I want to talk about some myths and some facts. Suicide myth. No one can stop a suicide. If people in crisis get help, they are often not suicidal again. We're talking about 80% of the people who were suicidal and received help no longer were suicidal again. Asking a person about suicide will make them angry and increase the risk. That's a myth. The fact is that actually opening up this conversation lowers their anxiety, opens up communication, and helps the individual. A lot of times we get the sense that somebody might be experiencing suicidal thoughts, and we want to ask, but we're hesitant because we think maybe it'll trigger them to think about it. No, it's not going to do that. Somebody who's suicidal, if it gets to that point, they've thought about that already. You're not going to put that thought in their head. And sometimes we're reluctant to ask the question because what if they say yes? Now what are we going to do? And I'm going to talk about that later. Another myth. Only experts can prevent suicide. That's really everybody's business, and that's one of the reasons why we're here, to try to help educate you on what some of the symptoms and some of the signs are, and also later to help you to learn how to talk to people about this. Just a couple more. Suicidal people keep plans to themselves. That's not so. Most people will communicate that they are planning on doing something. Sometimes, though, those messages are missed, and then after the person dies, then you say, oh, that's what they meant by that. Right? Okay. Just a couple more. Those who talk about suicide don't do it, and once a person decides to complete, there's nothing you can do to stop them. Those are all myths. Suicide is one of the most preventable kinds of death. Kevin Hines talked about many opportunities that people had to stop him. When he got off the bus to go to the Golden Gate Bridge, he was the last one off the bus. He's walking, the bus driver looks at him, and finally he says, somebody is going to reach out to me. Bus driver looks at him and says, get off the bus, kid, I got to go. When he was on the bridge, he talked about several people seeing him pace. Nobody came to him. He talked about, he was very quick there, but he talks about a German lady comes up to him. And he's thinking to himself, finally, someone is going to acknowledge my pain and ask me how I'm doing. That's all he wanted. And that's the woman came over to him and asked him to take her picture. And he did. And then he jumped off the bridge. All right, now, rates. Why is it difficult to obtain accurate rates on suicide? Who knows? Why is it so difficult?
Something that looks like a suicide might not be a suicide.
Some may not be identified as a suicide for other reasons, right? That's one of the reasons. Most of our estimates seem to be low. Many accidents, quote unquote, may be suicides. Some single car accidents, perhaps, not all of course, but some single car accidents might be suicides. Also, relatives, friends may not acknowledge that it was a suicide. So gaining accurate numbers is very difficult. That being said, we do have numbers. It's one of the leading causes of death in the world. You're talking about 1 million suicides worldwide per year, and you're talking about 1 million attempts in the United States. That's called a parasuicide. $44,000 people a year in the United States. Now, we have to get this, because that's a number, but we need to get a certain perspective as to what that number means. So that's about 120 a day. About 120 people a day kill themselves in the United States. Well, let's think about this a little bit more. What does that really mean? That would be, now think about this. That would be like an airplane crashing every other day in the United States. Now, can you imagine if there was an airplane crash every other day in the United States? The uproar, the outrage, there would be congressional hearings. I mean, it would be, but what's the difference? What's the difference? The difference is, with an airplane crash, God forbid, there is a crash site. There's 120 different crash sites. So we don't really see it because it's not big. There's a crash site in Iowa, in North Dakota, in Pennsylvania, in California, in Texas, and many other places. That's what the difference is. More numbers. 10th leading cause of death. Actual number, because of those other reasons, estimated to be 2 to 3 times higher. This is an interesting one. The lowest states suicide rate. New Jersey is 49th, New York is 50th, and DC is 51st if you count that as a state. The highest states, Wyoming, Alaska, Montana. Any clue why that would be? More, yeah, there's more population here, which means more services, more availability of services. What else? Somebody else? Taylor, I think you had your hand up. Abby, yeah. The isolation, less services, and one other factor between the states on the left and the states on the right. More guns, more firearms, more firearms, more firearms. Suicide rates. Pennsylvania's 33rd. That's where we are. Ages 25 to 44 is the largest number of suicides, but that's also the largest number in the population. 65 plus are the highest rates of suicide, 15.8 per 100,000. Elderly white male, 80 and above, are the highest category, 29.1 per 100,000. This is an interesting one. For men, the rate increases after 65. For women, the rate decreases after 65. I don't want to speculate what that's about, but that has to something, perhaps something with the male-female relationships. I don't know. Okay. Just a couple more stats here. About 3% of people will report that they contemplate suicide at some time in their life. 5 to 16% say they have current thoughts. But this is the frightening part. The Center for Disease Control in 2011 did a survey, and they gathered data for students from grades 9 through 12. And those are the numbers. 16 said they had serious consideration. 13% said they had a plan. 8% said they attempted, and almost 2.5% indicated that they were treated for an injury. This is grades 9 through 12. I believe in the Second Amendment, but this is a sobering number here. If there's a firearm in your home, there's 43 times more likely that a family or friend will get killed than an intruder. If you have firearms in your home, please lock them up. We hear so many times when children or somebody, a young person, finds a firearm and ends up getting killed. That's a sobering number right there. There's 6 very close survivors for every suicide. And their life changes. It's done. It's never the same. Right? Never the same. 6 close survivors. And when people get to the point where they are attempting suicide, they almost get into this spot where they can't see anything else except ending the pain. And they don't understand this part. They really believe that people will be better off without them, which isn't even close to so. And so what I often do when I'm treating somebody, I let them know this. And I let them know the legacy that they're leaving. And I let them know that what they've just done is they've increased the likelihood that loved ones, they've increased the likelihood 9 times that loved ones will attempt suicide. Attempts, 3 times more women than men attempt, 4 times more men than women complete. Why? Right. Correct. Right. Men are more likely to use firearms. Women are more likely to use pills. Correct. Also, they use more lethal means. Then the question is, maybe they're less ambivalent about it. And now also, you're going to see soon, alcohol and or drugs plays a strong part in this too. 25% leave notes, which of course means 75% don't. The notes that they leave are usually brief and vague and usually very positive about family and friends. Unlike the, what's that movie, 13 Reasons Why or something? Yeah, that doesn't usually happen, okay? This is a typical note. I don't know if you can see it. It says, I love my family with all my heart. I am sorry. I am depressed and in pain. Signs it and I love you. That would be a typical suicide note. It really doesn't say much and it really doesn't answer any questions. In fact, it often raises more. Okay. Suicide is also related to the social environment and to marital status. 50% of completed suicides were found to have no close friends. That shouldn't be surprising. Divorced people have higher rates than married or cohabitating individuals. Also, it seems to vary a lot according to race. White Americans, 2 times the rate of African Americans, Hispanic Americans, and Asian Americans. The major exception, of course, is Native Americans, which is about 1.5 times the national average. This graph shows you the suicides per 100,000 by population. And I want to show you this graph for a couple of reasons. When we talk about children's suicide, we're talking about the ages 5 to 14. When you hear statistics on adolescent suicide, what would make sense? When you think an adolescent, you'd think 13 to 18? No. What they mean is 15 to 24. That's the adolescent suicide. I think it's a stupid name. You should call it young adult suicide or something. They call it adolescent, which it also includes what? Most traditional college students, right? Then you have 25 to 44 as the next category, 45 to 64, and that's a typo there. That should say 65 to 74. So suicide generally increases with age. And then you see at the end it kind of levels off a little bit. Three groups we pay special attention to, and 3 groups there's a lot of research on. children, ages 5 to 14, adolescents, 15 to 24, and the elderly over 65. But they're not really elderly. No. We have to change that name too. That we definitely have to change that. Okay. Infrequent in this age group, infrequent, but it's been increasing. 6% among children between the ages of 10 and 14 are caused by suicide. Boys outnumber girls as much as 5 to 1. Now, it's difficult to see, but let me explain something to you, which is frightening. The heavy line, see the heavy line? That's motor vehicle traffic deaths. Okay? The dotted line, not the dotted line, the line with all of the dashes in it, that's suicides. You notice something? There's a laser on this, I don't know how to work it, but up there, you notice something up there, like around, say, 2013, 2014? What just happened there? There's more suicides, deaths in this age group than motor vehicle accidents. Okay, children. Often there's a behavior pattern that often precedes this. Running away, accident proneness, temper tantrums, personality changes, withdrawing. The old thinking used to be a child this age didn't really understand death. You know, they sort of wanted to be dead and wanted to be at their friend's sleepover the next week. Now the belief is they really do understand this. Adolescents. Second leading cause of death. Oops, let me just go back here. Second leading cause of death. 1,500 teens commit suicide in the United States. 10% make attempts. 16% have ideation. 50% tied to major depression, low self-esteem, feelings of hopelessness, anger, and impulsiveness. Rate of attempts to completions is probably 200 to 1, and the same ethnicity where white Americans seem to attempt and complete suicide in this age group more than African Americans, Hispanic Americans, or Asian Americans. College, 15 to 24 age group. If I were to go to downtown Stroudsburg right now and stop a person on the street and say, why would a college student attempt suicide? What would they say?
Stress.
Because of?
On schoolwork.
Schoolwork. That would be what they would say, right? Academic pressure. Is that the leading cause? No. What's the leading cause of suicide attempts on a college campus? Social problems. Social problems. What's the second leading cause? Family problems. Academic pressure, way down the list. What they do is they interview people who have attempted. And if it was academic pressure, when would most suicide attempts occur on a college campus? Finals week, right? When do most? Everybody knows that. Everybody knows that. That was a quick answer right there. When do most suicide attempts occur on a college campus? Within the first month, right? Because isolation, social problems, not fitting in. Just remember your first couple of days and weeks here. It was difficult, right? Okay. These are the feelings associated: depression, loneliness, isolation. Now, here's a frightening study. Frightening study. 3 different colleges, survey of close to 1,000 students. 80% said they had experienced depression since coming to college. 32% said they had suicidal thoughts. 4.5% said they had attempted suicide at some point in their life. And 1% said they had attempted suicide while they are students. So if there's 6,000 students, it's about what we have, 6,000 to 7,000, there may be upwards of 60 attempts. The elderly. In our society, Western society is more likely to commit suicide than people in any other age group, especially the 80 plus. Many factors: illness, loss of close friends, loss of control over their lives, and loss of social status. Oops. The elderly are typically more determined. That's why their rates are higher. Rates, and this is interesting, they're lower in Native American groups. Okay, what triggers a suicide? Recent events can trigger it. It could be the final straw, shall we say. But it's not usually the main cause for it. Stressful events, mood and thought changes, certainly alcohol and drug use, psychological disorders, and modeling, or the suicide contagion. Should come as no surprise that people who attempt suicide report more stressful events in their lives than people who don't. Some of the main stressors are combat stress. We're losing a lot of soldiers that come home. And there's a very strong link between suicide and post-traumatic stress disorder. And trauma and vicarious trauma. What's vicarious trauma? Anybody know what that means?
Not really experiencing the trauma, but experiencing the trauma through somebody else or watching it. Who would be at risk for vicarious trauma? It's also known as secondhand trauma. What do you know?
Like EMTs?
Yeah, first responders, absolutely, first responders. I gave a whole other lecture last year to first responders on the connection between post-traumatic stress disorder because of vicarious trauma and suicide. And just quickly, this is a survey, was the Journal of EMS. There was a question, have you experienced critical stress? And that was the definition of critical stress. And they were expecting a very low percent of the EMS people and first responders would respond to this survey. This is what they found. First of all, they were expecting about 500 responses. They had over 4,000. 86% said they had experienced critical stress. 37% said that they had contemplated suicide. 6.5% said that they had tried to take their life. This is a serious problem for emergency people and first responders. And many people now, with the hurricanes and the flooding in Texas and Florida and the islands, which seem to be neglected a little bit, many of the first responders are going to be at risk for post-traumatic stress disorder, let alone the citizens who experience that. 10 times the national average. Okay. Long-term stressors can include limited social support, serious illness, abusive environments, and occupational stress. And these are some of the occupational stress that tend to be correlated with suicide. Healthcare workers, dentists, lawyers, police officers, farmers, unskilled laborers. No provosts on there.
No faculty.
No faculty on there. No faculty on there. No. No. Okay. Now, just a couple more things here. Many times you see a change in the individual's mood and a change in the individual's thoughts. And there's an increase just in their emotional upheaval. And oftentimes they'll get preoccupied with thoughts of suicide and images of suicide. So, as many of you know, before teaching here, I was a director of mental health services at Pocono Medical Center for many, many years. And one of the therapies that we had there was called art therapy. It's a really good forum so people can express their thoughts and feelings in a nonverbal way, because sometimes people have a difficult time talking about this. So these are some actual drawings from people who were admitted because of suicide attempts or because they were stopped from committing suicide. It doesn't take a psychologist to figure this one out, that this person is in fact suicidal, right? These are actual drawings. This was an interesting one. The art therapist asked the patients to just do a free drawing, and this person drew a tombstone. Okay. This is another one. This is an interesting one. The art therapist asked the patients to draw a bridge from their past to their future. And what this person did was, that was their past, that red and black mess. That was the bridge, and that was their future. It says death. That's a drawing that sometimes people will see in your abnormal psych book. That was not from the mental health unit. The art therapist asked the person just to make a circle to try to structure the drawing and draw whatever you want. What does that say? I wish I was dead. Mm-hmm. And this last one is really, I think, fascinating, because certainly there's some artistic talent there. And you see that? And I don't know if you can read what was written over there. It says, depression, asleep in death. Okay. Also, we see changes in the way the person thinks. They become preoccupied, they lose perspective, they see it as it's the only effective solution to my problem. Hopelessness, again, occurs. They have what we call dichotomous thinking, black or white thinking. Things are either all good or all bad. The four-letter word in suicide is only, and it's the only thing I could do. They also have these other distorted thoughts. I mean, it's not psychotic thinking, but it's what we call cognitive distortions. They focus on negative events and they ignore the positive. That's known as selective perception. They draw negative conclusions on just a little bit of information. That's called overgeneralization. And oftentimes they will magnify the significance of a negative event. All right, now, alcohol and drugs. 70% of people who attempt suicide drink alcohol just before the act. Autopsies show 25% are legally intoxicated. Obviously, other drugs have similar ties. This is the lethal triad, right? You get an upset person, throw in a little alcohol, throw in a little firearm. Serious, serious problem. Okay. Psychological disorders, the majority will have a psychological disorder, often depression or bipolar disorder, certainly substance use disorders. One of the prime times for suicide attempts is when a person gets home from recovery. You have to monitor them very carefully, because that was their go-to coping mechanism. It wasn't healthy, but it was their go-to coping mechanism, and unless they have strong supports, they're at risk for suicide. Now the contagion of suicide. This becomes a real problem. We saw something locally the last couple of years, and I remember many, many years ago up at the Pocono Mountain School District, there was a series of suicides that followed each other. One acts as a model. Just by a show of hands, I often do this in my abnormal psych class, but just the students in here. By a show of hands, how many of you in your high schools had a peer commit suicide? That's a lot, right? That's a lot of people, probably about half, maybe even more than that. And some of your schools did what? What did some of your schools do when that happened? What did they do?
We had a bunch of grief counselors come in.
You had grief counselors come in. Why did the grief counselors come in?
I guess because a lot of us knew the students.
They came in to help you deal with the deaths. That was part one. But they were also doing something else.
Preventing more.
Trying to assess to see if some other ones are at risk. Right. Right. Okay? Because we worry about this. We worry about what we call suicide contagion. Okay. Suicides by family members, friends, celebrities. Remember, the one, Kurt Cobain, 68 documented suicides following his death. That was really sensationalized. I have to say, Robin Williams' suicide, I thought the media dealt with it pretty well. They dealt with it in a more educational way. This is from Active Minds. It's backpacks, sort of to symbolize all of these students who killed themselves. These are many of the warning signs. There's a handout in the back for you that has all of these warning signs. And there's some cards that have the hotline for Monroe County in the back also. All right, so when we're trying to assess, we're looking at some clues, right? We're looking at some clues. These are pretty direct verbal clues that somebody may say, I've decided to kill myself, I wish I were dead, I'm going to commit suicide, I'm going to end it all. If such and such doesn't happen, then I'm going to kill myself. Or if such and such does happen, then I'm going to kill myself. Those are pretty direct. People aren't usually that direct. Usually, they have more indirect clues. And you'll hear things like, well, maybe my family would be better off without me, or I'm tired of life, or who cares if I'm dead anyway, or I just want out, that sort of thing. Those are more indirect clues. Soon you won't have to worry about me any longer, right? Those are indirect clues. These are clues that if you need to follow up some additional questions, not shy away from it. You're not going to give them thoughts. It's a myth. Some of the behavioral clues, previous suicide attempt. Psychology majors know what's the best predictor of future behavior? Past behavior, right. Past behavior. Acquiring a gun or stockpiling pills. Depression, moodiness, helplessness. Putting personal affairs in order is often a sign, as is giving away prized possessions. Sudden interest or disinterest in religion. Drug or alcohol abuse or relapse, and unexplained anger, aggression, and irritability. Some situational clues that you can look for: being fired or expelled, recent unwanted move, loss of a major relationship, death of a loved one, especially by suicide. Diagnosis of serious or terminal illness, loss of freedom or fear of punishment, anticipated loss of financial security, or fear of becoming a burden to others. Now, any one of these in and of itself doesn't mean the person is going to try to commit suicide, but these are clues. So, what do? You need to ask, you need to talk, you need to listen, not shy away from it. If in doubt, don't wait. Ask the question. Be persistent. Wow. I don't know what just happened there. Okay, hold it. Okay, here we go. Talk to the person in a private setting. Spend some time. Give them your attention. Let them talk, right? If a person, if you're engaged with a person and they're talking about wanting to harm themselves, okay? Look what you have to look at all the good things in your life, or look what you have to look forward to, or that's lame, okay? It just is, all right? Because when they're to that point, telling them that they're a good person and so on, and pointing out all the good things about them, it's just lame. It just is. It's so far beyond that you need to do something else, all right? So, give them time, have resources handy. Everybody should just have a business card from MHDS with the crisis line with them, okay? Now, how you ask the question is less important than the fact that you do ask the question. There's only one way to not ask the question, and I'm going to get to that shortly. But these are some ways that you can ask a person a question. You can have the less direct approach. Have you been unhappy lately? Have you been very unhappy lately? Have you been so unhappy that you've been thinking of ending your life? Right? You ever wish you could go to sleep and never wake up? Those are indirect ways of asking. And this occurs in all parts of life. I remember many years ago when I worked at Pocono Medical Center, we had a consult on one of the medical floors because the nursing staff there thought maybe their patient was suicidal, but they didn't know how to ask, and so they called one of the psychologists down. So I went down and I introduced myself and I had the nurse come in with me, and I talked to the patient, and I sort of whispered to the nurse and say, okay, now I'm going to do my thorough suicide assessment. So is it so bad that you're thinking of killing yourself? That's what I asked. And the nurse was like, you can't. Yeah, you can ask that. That's fine. You can just ask that. Right? All right. This is a more direct approach. Sometimes when people are as upset as you are, they're contemplating suicide. Have you gotten to that point? You're telling me you're really depressed, it's hopeless, or are you thinking about suicide? This is how not to ask a question. There's only one way to not ask a question. Because really, what are you saying? I don't want to hear it, right? Okay. This is more for psych majors. I'm going to go through this quickly, but if you're in practice and you have a client that's suicidal, you need to do a further assessment. You need to assess the means, right? The behaviors, their intent. And again, for psych majors who are going to be therapists and counselors eventually, you're going to be dealing with this a lot. What would stop them from killing themselves? You need to assess whether you can treat them as an outpatient or whether they need to be hospitalized. Okay? There's sense of control and their objective identifiers. These are questions that you will learn when you take counseling or at your internship sites. Okay. Also, you need to find out from your clients if there's previous suicide behavior, because the best predictor of future behavior is past behavior. Okay, great. Okay. These are some of the protective factors that can help a person not attempt suicide. Social support, problem-solving skills, coping skills, conflict resolution skills, sense of belonging, spiritual connections, cultural connections. More protective factors. Okay. So, persuade. So we question people, then we have to try to persuade them to get assistance. Listen. Suicide is the perceived solution to the problem. Don't rush to judgment. offer them hope, then help them get help. Help them get help. Your willingness to listen and to help can rekindle hope and make all the difference. Refer. The best referral is you take the person to someone. You accompany them. Or if it's serious, you take them to the emergency room. The next best referral is you get a commitment that they will accept help and make arrangements to get them help. The third best is you give them referral information and get a good faith commitment. I recommend first or second, not the third. Since almost all efforts to persuade someone to live will be met with agreement, do not hesitate to get involved. So, one more story and then I'm done. Okay? Start with a story, have to end with a story. So this is a story about an individual who was born in 1809. His infant brother Thomas died at age 3. His great aunt, his uncle, and his mother all died when he was 9. His sister Sarah, who then raised him after his mother died, she died when she was 19. His best friend died when he was 26. At age 31, he experienced 6 months of severe depression. His friends were so concerned that they, their words, removed razors, pistols, etc. from his room and presence for fear that he might commit suicide. He described himself as the most miserable man living. To remain as I am is impossible. I must die or get better. He had a really good friend, Joshua Speed, who remained with him during this period of time. About 6 months later, Joshua Speed needed to leave because Joshua Speed's father died. And this individual told Speed that he was feeling better and insisted that Joshua Speed go to his father's funeral. Who is this person? Who is this person I'm talking about? Anybody want to guess?
Edgar Allan Poe.
No? That's a good guess, though.
President Lincoln?
Yeah. Lincoln. Lincoln. Right. Again, let's go back to my first statement. Depression is not a disorder of the will, right? How could it be? Okay? All righty. Okay? Hope helps prevent suicide. There's another thing we keep saying. Silence equals suicide. No, speak up. Ask. I didn't do that. Emily did all of my slides. Emily did all of my slides, so I want to shout out to Emily. So a couple of shout outs. Suicide Prevention Coalition of Monroe County. Anybody here from the Suicide Prevention Coalition? I saw Chief Parrish was here. And from the Children's Roundtable, anybody here? Shout out to them, Children's Roundtable. And now we have a video I want to show you, very brief. It was developed by the Suicide Prevention Coalition of Monroe County.
I have the right to feel what I'm feeling.
Right now. I have the right to seek help for a friend who may be hurting himself.
I have the right to ask.
To ask her if he is thinking about suicide.
I have the right to ask for help.
I have the right to talk to someone.
Because I deserve to feel happy.
Safe.
Comforted.
to live.
What's in there? Safe. I messed up the exam. What did you do? I love it.
Pretty good for local production. Yeah. Okay, these are the references I had. Oh, that meant I'm done. These are the references. These are all of my references for the various slides. Oh, wait a minute. Here we go. Also, afterward, I'm going to take questions, but afterward, I do have many colleagues. If any of you want to talk about anything personal or a friend or a family member, I have Dr. Hodge, who's here. Professor Emeritus Dr. Bartoli is here from the Psych Department. Dr. Eschen is here from the Psych Department. So if anybody needs to speak with us personally, we certainly make time for you. So now I can do this. I'm done, but I will entertain any questions that you have. So. Any questions, anybody? I know it's late, but yes.
I wanted to know, I mean, it's something that I've read about because my platform is trying to reduce the rate of suicide in youth. How come one person can commit suicide and another cannot? Like maybe one girl can have boyfriend break up with her, she says commit suicide, and another.
So the question is, why does one person perhaps attempt suicide or commit suicide and the other person doesn't? The one person that does attempt or complete suicide maybe is suffering more from depression and hopelessness. The other person may feel there's hope for the future. They may believe that there's a really bad time. Or the one person may have social supports that the other person doesn't.
What about the way they say that the melatonin, the serotonin in your brain? If most people who commit suicide don't have enough serotonin in their brain.
Okay, I'm glad you brought this up. This serotonin thing, right? The serotonin issue, yeah. Okay, so I figured someone was going to ask this question. So let me just explain this whole thing with what the antidepressants do and the serotonin, okay? And Emily, could you put those slides back up again? All right, I know several people are leaving, but just bear with me for 1 second, okay? Bear with me for 1 second. So I want to answer this question because I often hear this. The person is depressed because they have a chemical imbalance, serotonin. And so I often get asked, how do I get checked for a chemical imbalance? You can't. There's no such test. Now, maybe 20 years from now there is, but there's no such test now. So then we say, well, the person takes an antidepressant, and it affects the serotonin levels, right? And so now they feel better, so must be low serotonin. Well, at first glance, that seems to make sense, but psych majors here know correlation doesn't equal causation, right? You all know that. You better know that by now, right? Okay. So just because two things are connected doesn't mean one is causing the other. So then I do this test. I say to people, okay, have you ever experienced a headache in your life? Yes. And what did you take for your headache? Advil. Advil is ibuprofen. So why did you have a headache? No, it was simple. You didn't have enough ibuprofen in your system. That doesn't make sense, does it? That doesn't make sense. So why does this other thing make sense? Right? Okay, so, you get it back up? You all know what a neuron is, right? A neuron. A neuron is like a tree, right? It has its branches, which are the dendrites. It has the axon, which is the trunk. And it has the axon terminals, which is the roots. Everybody remembers that, right? Okay, so now the serotonin goes through the neuron, and there's billions of these in our brain, goes through the neuron, goes across the space, which is called synapse, good. and then gets absorbed by the next neuron, right? Okay, so what do the antidepressants do? What are they called? SSRIs. What does that stand for? Selective serotonin reuptake inhibitors. So there's, oh, wait, just go back. There it is. So there's, see, boom. Okay, just go to the next slide. What does that mean? Say it backward. It inhibits the reuptake of serotonin selectively. Go to the next slide. This is serotonin, right? Going from the axon terminal of neuron A to the dendrite of neuron B. Not all of it is getting through. Some of it is staying back. What does the medicine do? It lets more get through. It inhibits the reuptake. It prevents it from going back into neuron A. It lets more get through. That's all it's doing. It's not adding anything. It's not subtracting anything. It's letting your brain use what's in it more efficiently. Now, the million-dollar question is, why does that happen? And I don't know that. If I knew that answer, I'd be golfing every day on an island that I own. So nobody knows that. So it's a chicken-egg argument, right? Which came first? Is that creating the depression? Is the depression creating this? So that's what the problem with when people say I have low serotonin. It's not low serotonin. It's not being used efficiently. So SSRI, say it backwards, inhibits the reuptake of serotonin selectively. That's all the medicine is doing. Now, if I had a chemist here, they would be laughing at me, but I'm just making this as simple as possible. Okay, any other questions? Yes?
What is your take on like assisted suicide, like older people and for like medical reasons?
Oh, assisted suicide with older people with medical reasons. Wow, that's a really good question. I guess I have mixed feelings about that. I don't know. There's my spiritual side, which basically says that's somebody else's business, and then there's the humanitarian side where I see people suffering a great deal. I don't know. I think that's just a personal and family decision. Yeah. But that's an excellent question. Yeah. Other questions that aren't as tough? Any other questions?
I guess
yes,
I have
sure.
one quick one.
Mm-hmm.
If I have a friend that just lost somebody to suicide,
Mm-hmm.
you were talking about they're 9 times more likely to
Right.
do something. Like, how do you approach them? What do you
Yeah.
do? What's the right way to do it?
Yeah, that's one of the other myths that I should have put up there, that people who lose somebody from suicide don't want to talk about it. They do.
Yeah.
They do want to talk about it. They do. You know, approach them, say, hey, how you doing? Can we talk? If you believe that the person is at risk, you can refer them to one of the counselors. They do want to talk about it. This silence, even after the fact, everybody thinks, well, I don't know what to say, I don't know how to approach it. Just approach it. It doesn't matter how you really do it. Yeah. Open it up. Yeah. Other questions? Yes?
What do you think is the best way to, besides conversation, remove the negative connotation around mental illness?
That's another really good question. Removing the negative connotation around mental illness, yeah. Well, I think things like this help in that we understand that depression is not willpower, that it's an illness. Having conversation helps. And I like to think that we're maybe a little more sophisticated with understanding mental illness than generations past. But then I read a number in one of our abnormal psych books that said 31% think mental illness is due to, I don't know, like the devil or something like that. I mean, just you know. I just think more education and more conversation, and I know on campus we have Active Minds, which is an organization which is really trying to help people understand this. We have our Psych Association. We do Mind Fest here. So There's a lot of activities on campus. I guess the best thing I would say is get involved. There's walks for suicide, there's mental health walks, National Alliance for the Mentally Ill. So try to get involved. And when you hear somebody, here's the other thing, when you hear somebody saying something derogatory, confront them. Say, no, that's not so. Other question?
There's actually a suicide prevention walk tomorrow, starting at 6 o'clock and finishing at 5. Just so I can-
Suicide prevention walk tomorrow. Perfect. Other questions?
I'm back to the same question. Okay, you said it's because someone might have a support team, but you can have two siblings where one like has depression and the other doesn't. Then in the same household, they have the same support. So that goes back to me where I sometimes think that there are people who are born with depression, just like these people. It could be like a family history.
There is a genetic predisposition to certain illnesses, right? There's a genetic predisposition. Psych majors, what do we call that? Diathesis stress theory, right? You're predisposed to certain illnesses. So if you're predisposed to depression, then you have to be extra careful to make sure you have a support group and people that you spoke with. But that's not just for depression, that's for many illnesses. I have a family history of heart disease. Does that mean that I'm destined to have heart disease? No, it's a risk factor though. It's a risk factor. So I have to be very careful, make sure I don't smoke, make sure my cholesterol level is okay, make sure I exercise, you know, all that boring stuff. I have to make sure of that because if not, I'm at risk to get heart disease. So people with depression or even people with bipolar disorder or, people with alcoholism and addiction in their family, you better be very careful because that's a huge risk factor. So we look at risk factors. So there is a biological component to it. What that actually is and the percent, we don't really know yet. Again, maybe 20 years from now, we're going to find that there's a gene for schizophrenia or a gene for major depression. We're not even close to that level yet. Any other questions? Another quick shout out to my mother. Thank you. And my sister. Okay. Thank you. All right.